to speak with you and have the opportunity to co-present with my esteemed colleague, Dr. Leandro Mena. And so I'm Vincent Ramos. I'm from New York University and from the Center for Latino, Adolescent, and Family Health. And I'll be presenting with Dr. Mena, who will be speaking very shortly, who's professor at the University of Mississippi Medical Center, the chair of the Department of Population and Health Science, and also the director of the Center for HIV/AIDS Research, Education, and Policy. We actually spent quite a bit of time talking about what we could present today that would be of interest to all of you who have given us the honor of being here today. And we wanted to talk about 4 things and make some points. And so we are going to talk about HIV, sexually transmitted infections, HCV, and the COVID-19 sort of pandemic as they relate to the Hispanic Latinx community in the United States. And we're going to try to make some arguments about these being overlapping public health crises and really try to make some points. So next slide, Judith. So I think this is a great place to start. You can see here that these are just figures that represent sort of national public health priorities. And so I think most of us know that we have a plan to end the HIV/AIDS epidemic in our country. We've actually made significant progress in ending the HIV/AIDS epidemic. We have a plan, we actually have a couple of plans, but we have a federal action plan for addressing sexually transmitted infections in the US. We have a national viral hepatitis plan, and we also have increasingly evolving guidelines in terms of how we can resume whatever our new normal will be in terms of the coronavirus. And so I mentioned these 4 plans because I think it makes sense to think about them from a Latino perspective. And I want to start by sort of making a point that will be in the next slide. So next slide. That when we think about the Hispanic Latinx communities in the United States, I think that HIV, STIs, HCV, and COVID-19, they're overlapping epidemics. And I think what's important for all of us, and hopefully one of the things that our presentation will communicate, is that there are underlying drivers that actually are sort of responsible for these overlapping epidemics, and that for the Latino Hispanic community, that oftentimes these contextual drivers remain overlooked, they are inadequately addressed, and they warrant specific attention. And so future sort of prevention and control efforts, if we think about those 4 plans that were on my previous slide, we need to consider how the contextual drivers interact, to actually create the disparities that are enduring in the Latinx community across the United States. Next slide. So let's start with HIV. And so I think a lot of these data folks may be familiar with, but just to make sure that we're speaking kind of the same language, the most recent data, you can see the source at the bottom of the slide. You can see that we have estimated, we have annual new HIV diagnoses on the left. And so if you look at the figure, what you can see is that overall, the color that's in the purple, there's been a 13% reduction in the period 2010 to 2018 in the overall new HIV diagnoses. If you look at African American and white, same basic pattern. There's been a reduction of 17% in African Americans, 16% in white. What's striking is that there's a 5% increase in new HIV diagnoses in the Hispanic Latinx community. And I guess I've heard people interpret that number in different ways. One interpretation is that new diagnoses suggest that we're doing a better job with testing, and that in fact what's happening is that established HIV infection, people who didn't recently acquire HIV but who have had HIV and been undiagnosed for a long period of time, are actually being diagnosed. So that's one sort of idea about what might explain that 5% increase. But I think what's important to also consider is what's on the bottom. And if you look at the bottom, these are the estimated annual new HIV infections. And again, the same basic pattern emerges. What you see here is overall, there's been a 4% reduction. In the African American community, there's been a 4% reduction. In the white community, an 8% reduction. And so what this figure at the bottom left is really referring to are new HIV infections. So these are not established infections. These are estimates of recently acquired new HIV cases. And what you see in red is that the Hispanic Latinx estimated annual new HIV infections is an increase of 6%. And so I think it's important to consider whether or not the new diagnoses, if they really represent sort of established HIV, or if they really are sort of, tapping into the fact that HIV is being transmitted among Latinx Hispanic communities, and that these new diagnoses are in fact new infections. If you look on the right, the CDC has been really working on some very interesting surveillance. And one of the projects that they have been working on is something called molecular surveillance. And these are sort of places in our country. And if you look at the map, there are 60 what we call high transmission clusters. And so these high transmission clusters are spread out all over the United States, but they tend to sort of aggregate in certain places where there are more clusters than others. But what's interesting about these clusters, that these are networks, whether they be sexual or drug networks, where HIV is being transmitted at a rate that's much higher than what we would expect to happen if we think about the national average. And so some of the clusters have transmission events that are 33 times the national average, but they range from 5 to 33 times the national average. So these are places where HIV is transmitting, where there are new infections, and where the rate of transmission is happening much more rapidly than what we would expect. When we take a look at the 60 high transmission clusters, and we try to make sense of who really is represented in these clusters. And so I've shared with you that there are 60 clusters. I've also shared that they're scattered across the United States, but they do tend to be clustered in certain areas. But if we took a closer look at who's inside of the cluster, what we see is a very interesting dynamic. And so the first thing I want to point out is that if we look at the individuals that are in the rapid growth clusters, that about 70%, the vast majority, are under the age of 30. If you look to the left, you see 83% are MSM, and about 40% are Hispanic Latinx. And so, this is a way of saying that for Hispanic Latinx, young MSM, that they're overrepresented in these transmission clusters that are actually scattered across the United States, where HIV is being transmitted at a rate that's much greater than what we would expect. Next slide. So I want to spend a little time talking about sexually transmitted infections. And so here you can see reportable STIs in our country. And so there's some data that suggests from the most recent CDC report that for the 5th year in a row, we've had increases in reportable STIs. And so we have more reportable STIs now than we've ever had at any point in our history. And what's important about this is that for 5 years straight, they've been going up, and we're at an absolute record high. It's really, I think, wise to point out that these are just reportable STIs. All sexually transmitted infections are not reported. And so this is just looking at data that we have for the ones that are in fact reported. So if you look here, you can see that approximately 1 in 5 of all reportable STIs with known race ethnicity are among Hispanic Latinx. And so, 1 in 5 of the reportable STIs are Hispanic Latinx. For those cases where we know what their race ethnicity is, there are in the reporting systems, there are times, and we'll see this a couple of times in my presentation, where we have individuals who report having an STI, but we don't know their race and ethnicity. But I think this still suggests that a significant proportion of the reportable STIs are occurring among Latino Hispanic populations. Look at the percent change. From 2014 to 2018, you can see that the percent change in reportable STIs among Hispanic Latinos is 26%. So from 2014 to 2018, there was a 26% increase in reportable STIs among Hispanics and Latinx populations in our country. The maps on the bottom really speak to this concept of overlapping geographic spaces. And so you can see that the darker areas like California, Texas, Florida, New York, and then also on the left, which represents HIV, and then on the right, reportable STIs, they're overlapping. That where we see sort of increases in HIV, we also see increases in sexually transmitted infections. Next slide. So hepatitis C among Hispanics and Latinos. And so from 2013 to 2017, over 13,000 Hispanic Latinos died from hepatitis C virus complications. You can see here on the sort of age-adjusted hepatitis C death rates per 100,000, the light blue represents Hispanic Latinx, and the sort of dark blue is overall. You can see that the Hispanic Latinx have higher rates of hepatitis C-related deaths relative to the overall population. And so this is really of great concern because we actually, and this is amazing, we actually have very effective treatments that if folks are sort of screened or diagnosed as having sort of chronic HCV infection, that they can be treated for that HCV infection. And in most cases, they can become virally suppressed and actually achieve what we would consider a cure. And so you can see here that Hispanic.
Thank you. Oh, all right, sure, yeah, you're welcome. Yeah, have a good day.
I can hear people talking, I'm sorry. What you can see here is that Hispanic Latinx are among the least likely to be treated for chronic HCV and to achieve what we call sustained virologic response, which is another way of saying cure. And so you can see on the bottom that overall is the dark blue line, but the sort of light blue line is the line, or the two bars that actually refer to Hispanic Latinx. And you can see less likely to be treated and less likely to achieve sustained virologic response or a cure. Next slide. So COVID-19, this is something that has been sort of in recent months, since March, it's been sort of at the forefront of the public health efforts in our country. And certainly in New York City, where I live, it's been sort of an epicenter of COVID-19. What you can see here is that we have roughly 1.8 million sort of diagnosed cases of COVID-19 in the US as of June 1st, 2020. This is an important number because it only represents those that have been diagnosed. It doesn't represent those that actually are infected but didn't get tested and so had no way of being diagnosed as having COVID. But this is a way of saying that we have a lot of people in our country that actually have tested positive for the COVID-19 virus. If you look at the sort of bottom part of that first column, you can see here that we have more than 104,000 deaths. And this is also as of June 1st, 2020. And so many people in a very short time span, just from March to June, have died from complications associated with the coronavirus. If you look in the middle section of the slide, you can see that Hispanic Latinos account for 1 in 3 of all confirmed cases of COVID-19 with known race ethnicity data. And so again, about a third of all the confirmed cases are being classified, if we have race and ethnicity, as being Hispanic Latino. If you look below, you have roughly a little more than 1 in 4, but roughly 1 in 4 of all COVID-related deaths with known race ethnicity data are Hispanic Latinx. And keep in mind what I said earlier about the idea that in many instances, we don't know what their race and ethnicity is, so they can't be attributed to any particular group. But what I'm presenting here, even with the large amount of data that is missing race and ethnicity, that we know that significant numbers of diagnoses from COVID as well as deaths are actually Hispanic Latinx. If you look on the right, this is really interesting. Pew did a study, and they contacted a national polling firm, and they conducted an online survey that was nationally representative of the Latinx Hispanic community. And I thought this was interesting. From March to April, you can see here that they reached out to Latinx Hispanic individuals across the country. And what they found was that the person who actually filled the survey out, or someone in their household, you can see Hispanic, African American, and white, that 61% reported in April 2020 of the Hispanic Latinx folks that they spoke to in this national survey indicated that they lost their job, they took a pay cut. And so you can see relative to African American and whites that the economic impacts of COVID-19 are actually quite great. And based on this one data source from the Pew study, it suggests that the Hispanic Latinx community is being disproportionately impacted in terms of the economic consequences associated with COVID. Same basic pattern on the bottom, but this is not from Pew. This is coming from the US government, from labor statistics. And you can see here unemployment rates. And I would say this is from April 2020, so coronavirus started in March. If we look prior to this, I would say that unemployment rates are probably closer to 6 or 7% among Hispanic Latinos, but in April 2020, 19%. And so dramatic numbers of Hispanic Latinos across the country indicating that they're unemployed or they've taken a pay cut or they've lost their job. Next slide. So I want to sort of focus on two contexts to sort of tell a tale of two geographic areas. And I think that the purpose of highlighting the two geographies is to try to understand this overlapping concept and also to look at the underlying contextual drivers. And again, we're going to look at HIV and STIs, HCV, and COVID. For for my part of the presentation, I'm going to focus on the Bronx, New York City. This is the borough that I was born in, where I've worked for the past 2 decades. And I think what's interesting about the Bronx is that 1 in 2 people who live in the Bronx residents, are Hispanic Latino. And so the Bronx is a Latino borough. And I think Dr. Mena, Leandro, is going to focus on the Southern United States. And he's going to be talking probably more specifically about Hispanic Latinx communities, particularly Latino, Hispanic MSM, and use that as a case study for getting across some important ideas about overlapping epidemics, sort of a call to action, and also sort of next steps of what we can do. But I'm going to sort of try to weave the story by starting with the Bronx. Next slide. So a little bit about the Bronx. I think it's important to think about HIV and STIs, the coronavirus, and also hepatitis C within, the broader sort of context that I would call a context of inequality that really, is quite pronounced in the Bronx. The Bronx has come a long way from the time when I was a kid and lived in the Bronx, but the Bronx still lags behind. And so I mentioned already that more than 1 in 2 people in the Bronx are sort of Hispanic Latinx. And so 50% of the Bronx is Hispanic Latino. And if we were to look at the other 50%, what you would find is that overwhelmingly it's African American. The Bronx is the borough in New York City that actually by far are persons of color, Latino and African American. We also know that the poorest congressional district in the United States is actually in the South Bronx. I believe is congressional district number 16. And that is important because that's also a context where we see many of the things that we've been talking about today. In terms of the specific Hispanic Latinx communities in the Bronx, you can see overwhelmingly Dominican, Puerto Rican. Increasingly in New York City, there's been a large sort of community from Mexico, in particular the state of Puebla, that have come to New York City. So the New York City Bronx Latinx Hispanic community is quite diverse. The Bronx is really designated as a medically underserved and health professional shortage area. So that means that there's greater need and there are more people with health or social welfare needs than the actual providers that are there. And so we think about doctors or nurses or other kinds of helping professionals, psychologists, social workers. There's a disparate, an unbalanced ratio between the need and the numbers of people that are there, provide care. If we think about, individuals living in poverty, what you see is that 1 in 4 Hispanic Latinos that live in the Bronx live below the poverty line. And I would say that if I were really sort of more accurately reflecting the numbers, I would say that just above the poverty line, because really the 25% is below the poverty line. But if you think about the wages of your average person that lives in the Bronx, what you would find is that a significant number live just above the poverty line, and actually could be what we call transient poor, that if they have just one unfortunate thing that happens, maybe they get sick or, they have an extra expense, or maybe their car needs a repair, that potential cost could push them to a place where they may actually fall below, but they may be going up and down and be considered transient. The rate of psychiatric hospitalizations in the Bronx is higher than any other New York City borough. And so why is this important for us? It's important because psychological distress is often associated with the context in which people live. And so as people are experiencing more stressors, as they have more day-to-day pressure on their life, things are harder, they have more conditions of adversity, then they have more psychological distress. And in the Bronx, that manifests itself as more psychiatric hospitalizations. You can see here that when residents of the Bronx are asked to report on their health, they actually report their health as being lower than in any other New York City borough. And you can see here that more Bronx residents report having unmet medical needs relative to any other borough in New York City. And you can see that premature deaths, or deaths that occur prior to what one would expect in terms of a normal life expectancy, are much more common, close to 80% more common in the Bronx relative to New York City as a whole. This is really striking because the Bronx is only a couple of subway stations away from Manhattan, where if I was presenting all of these numbers for most of Manhattan, they would be dramatically different. So this is the context that I want us to think about what I'm going to say next. And I'm going to talk a little bit about sort of, again, HIV, STIs, hepatitis C, and COVID, but using this context of inequality as a backdrop. Next slide. So here's the overlapping epidemics. You can see here that each of the 4 outcomes that we are focused on today. I just picked one reportable STI, chlamydia, but I could have picked gonorrhea or another reportable STI, and you would see the same basic pattern. The dark area that is highlighted in the box is the Bronx, and you can see that the Bronx stands out as being a place where we see chronic hepatitis C infection, HIV diagnoses, COVID-19, and also chlamydia case rates. Next slide. So let's actually go through these and sort of illustrate a bit and just a couple of examples. And so the Bronx has the highest rate of new HIV diagnoses among Hispanic Latinos in New York City. And so I think that's very important, especially if we keep in mind what I said earlier about this relationship between diagnoses and also new cases of HIV. But only 1 in 2 Hispanic Latinx in the Bronx have tested within the past 12 months. If you look at sort of PrEP, 1 in 3 New Yorkers in New York City, so not New Yorkers in New York State, but in New York City, is Hispanic Latinx, but only 1 in 6 are PrEP users. And 1 in 5 New Yorkers, again, New York City, lives in the Bronx, but only 1 in 10 PrEP users does. And so there's this disconnect between people who are Latino and on PrEP and people who live in the Bronx and are on PrEP. And if you think about people living with HIV and viral suppression rates, we've made great progress in terms of sort of getting more people virally suppressed. The challenge is really sustaining viral suppression. But even when we think about achieving viral suppression as measured at sort of last appointment, you can see here that viral suppression rates for Hispanic Latinos in the Bronx are lower than any other borough. So the Bronx is a hotspot for testing, for increasing PrEP uptake, and also for helping people who are living with HIV to sustain their viral suppression. Next slide. So really quickly, STIs, the same basic pattern. You can see here chlamydia and gonorrhea. You can see basically the case rates per 100,000 for the Bronx. You can see the age groups. And so I think what this slide is getting at is that youth represent a key population. You can see that the trend for Latinx youth from 2009 to 2016, you can see there's been a 50% increase in chlamydia and gonorrhea cases among Latinx youth in the Bronx, ages 10 to 29, and half of the Latinx youth in the Bronx are younger than age 30. If we think about YRBS data from the CDC, you can see condom use at last sex. These are Latinx high school students in the Bronx from 2009 to 2017. At last reported sexual intercourse, only 45% of Latinx high school students indicated in the Bronx that they had used a condom. This says nothing about whether they used it correctly or consistently, but look relative to 2009, there's been a dramatic reduction from the 71% that reported to where we are today. And so again, this is sort of highlighting that the context of inequality, that these disparate outcomes are occurring, and you can see that there's a basic pattern of overlap and that certain populations are standing out as being more vulnerable relative to others. Next slide. So HCV, you can see here the chronic HCV rate per 100,000. The Bronx is higher than the other boroughs. You can see less than half of all people in the Bronx who tested positive for HCV in 2017 initiated treatment by the end of 2018. So again, a lot of people in the Bronx who in fact may be eligible for treatment for HCV are actually not initiating their treatment. And then if you see on the sort of the right column, you can see the Bronx has the highest rate of HIV, HCV co-infections. And you can see Hispanic Latinos accounted for 2 and 5 of all HCV, HIV co-infection diagnoses across New York City from 2014 to 2017. So a lot of Latino Hispanic co-infection in New York City, and the Bronx has the highest rate of co-infection. Next slide. And so coronavirus, you can see here, 1 in 3 coronavirus deaths in New York City are among Hispanic Latinos, the highest of any demographic. The Bronx has the highest rates of COVID-19 hospitalizations and deaths of any borough. You can see 2 in 5 non-healthcare essential workers living in New York City are Hispanic Latinx, and Bronx residents make up roughly 20% of all non-healthcare essential workers in New York City. And so this is interesting in terms of testing. 1 in 4 people tested for COVID-19 in the Bronx have tested positive, higher than in any other borough, but yet in New York City, the Bronx is 3rd in terms of number of tests that are performed. Next slide. But pulling this all together, I'm about to turn it over to Dr. Mena, but just to kind of make a couple of points, and hopefully if I've been successful, these points have kind of been apparent in the slides. I think, you know, we've made much progress across some of these areas, not all, but certainly with HIV, you know, as a country, we've made great progress. We are starting to sort of, you know, we have great treatments for HCV. We're starting to open up the country and try to resume a new normal. We still have great work to do in terms of STIs, but when we think about, you know, these 4 health outcomes in terms of a Latino Hispanic community in our country, what we see is that there's an overlap, and that the nature of these epidemics in the Hispanic Latino community suggests that there are underlying drivers, and that those underlying drivers are important for understanding the disparities that we see, you know, not only in the Bronx, but across other hotspots that are represented with large concentrations of Hispanic Latinx populations. Our programmatic efforts should address not only the national priorities as depicted on the first slide that I presented, but we need to do a better job at taking a look at how those national priorities can be better aligned with the needs of the Hispanic Latinx community. And if we're going to achieve our targets, it's not going to be possible without addressing the specific needs of Hispanics and Latinx populations. I'm going to turn it over to Dr. Mena, who's going to pick up and talk about the South and also make some points about new directions and Latino MSM. Thank you very much.
Good afternoon, and thank you, Dr. Guilamo, for the introduction in the first part. Thank you, everyone. And I really want to echo, you know, sentiments and appreciation that Dr. Guilamo presented at the beginning to all of you and to the National Commission, National Latino Commission for the invitation to be here. So for the rest of the presentation, and I know I'm going to try in the next 15 minutes or so to talk about, you know, the HIV epidemic, especially as it concerns the Southern United States and the Latino MSM in the South, which are, you know, a group that is significantly disproportioned by this epidemic. As you know, for many years now, the United States HIV epidemic is centered in the South. More people living with HIV reside in the South than any other region in the country. The South has only 42% of the population of the 38% of the population in the country, yet 42% of people living with HIV live in the South. In 2018, 51% of all new HIV diagnoses were in the South. And the South, you know, had more diagnoses of HIV infection among MSM, 12,664 diagnoses in 2018 than any other region. The largest group of MSM with the diagnosed with HIV infection in the South were Black African Americans, followed very closely by Latino. I will be, next slide, I'm sorry. So I will be, you know, next slide. So you can see in the South, people of color, MSM of color, Blacks and Latinos are disproportionately affected by HIV. And I'll be remiss, next click. Oh, go back, I'm sorry. Remiss, I just want to point out in this slide how in the West, Latinos represent the group that is, Latino MSM are the group that is, has the highest number of HIV diagnoses in 2018. Next slide. So these disparities are not more stark than when they are presented as the lifetime risk of HIV diagnosis. which since previous estimates based on 2004-2005 have decreased among both men and women by 21% and 44% significantly, respectively. The risk of MSM is 88 times higher than heterosexual men. And so you can see the lifetime risk of a Latino MSM is 1 in 5. 20% of all Latino MSM will become HIV infected. And while this is a probability, you know, and there are things that we can do to prevent that, I will show you in the following slide how in many ways this has become a reality. Next slide. So as you can see here, this is a study done by Eli Rosenberg in 2000, published in 2018, that used data from 2013, 2014, where several states in the South, like South Carolina, Mississippi, my home state, Latinos Latino MSM living in those states have an HIV prevalence that is actually about to reach, and in the case of Mississippi, slightly above 20%. Next slide. So the question is, I mean, how well are we doing in Latino populations, you know, treatment, you know, as prevention? So an estimated 83% of Latinx living with HIV are aware of their HIV diagnosis, which means that about 5 in every 6 Latinos who are living with HIV, you know about their HIV diagnosis. Among those, 73% received care, 58.7% were retaining care, and 63.7% had a suppressed viral load at the most recent viral load. Next slide. Sorry, next slide. So I think, you know, it's important to understand the steps to reach viral suppression. And here, you know, we can see the Garner cascade, you know, which presents with many challenges and opportunities. And we think about, you know, the diversity of Latinx population in the United States, you know, and how different constructs and different, you know, backgrounds and experiences, you know, we can present as challenges and opportunities. We can see how on the next slide. Now, these situations can really, you know, create, you know, important disparities at the level of diagnosis, receiving care, retention in care, and viral suppression. Some of these disparities are not unique to Latinos and affect really, you know, everyone who may be living with HIV, like lack of insurance, low income, lack of stable housing, low social support, all of which can have an impact in decreasing the number of people who can be retained and reach viral suppression. And overarching, you know, all these stages, I mean, it's really the stigma to HIV that represents a significant barrier. Next slide. In prevention, the CDC estimates that 1.1 million Americans are likely to benefit from pre-exposure prophylaxis. About 500,000 of those identify as African American, 300,000 are Latinos, and 300,000 are whites. Next, click. But out of the 220,000 individuals who, at the end of who at the first quarter in the first quarter of 2018 were thought to be prescribed PrEP, Latinos, who represent 25% of those individuals who can benefit from pre-exposure prophylaxis, only represented 3%. Next click. Next click. And as you can see here in the South and in the West, you know, the proportion of Latinos who can benefit from PrEP is even smaller. Next click. So Latinos MSM, especially Latino MSM, have significant challenge. You know, there are significant challenges for prevention and care in the South. The first one being access to care, poverty and lower education, understanding the heterogeneity of the Hispanic Latinx community. I mean, very often the issue around US born and foreign born that becomes a more relevant issue, especially, you know, especially in communities, in some communities in the border of the border between Mexico and the United States, linguistic and cultural competence services, discrimination and racism, HIV stigma and homophobia, Latinx healthcare workforce and service providers, which very often are terribly underrepresented in the overall healthcare community. Challenges for new immigrants and migration patterns, anti-immigrant policies and health-related immigrant bills, lack of Hispanic and Latinx research and researchers, and lack of knowledge about the healthcare needs and challenges that Latino communities face. For example, there is very little known about the health and mental health of gay and bisexual men and Latino men, and findings may vary among Latinos who are Puerto Rican in Connecticut or not represent Mexican Americans who may live in Southern Texas. More studies are needed on the history of child abuse and substance abuse among gay and bisexual Latino men. Next slides. So it's in this context that progress towards reduction of new HIV infection has stalled out in the recent years. New federal initiatives hope to capitalize the focusing the DHHS ending the HIV epidemic, a plan for America in the 48 counties that in 2016-2017 accounted for more than 50% of new HIV diagnoses, and including 7 states, 6 of which are in the South, with a substantial number of HIV diagnoses in rural areas. This challenge is a difficult one, as the HIV epidemic increasingly affects disenfranchised populations and is a reflection of health disparities. The ending the HIV epidemic has 4 pillars: diagnose, treat, prevent, and respond, with an overall goal to reduce the number of new HIV infections by 75% in 5 years. Next click. And by 90% in 10 years. But remember, Dr. Guilamo just told us, that the total number of new infections and new diagnoses increased among Latinx populations by 6% and 5% respectively from 2010 to 2018, which suggests that in order to meet the goals for Latinx populations, we will have to significantly increase our investment with special attention for those most marginalized populations. For example, the Latinx trans community. Next slide. Here are some strategies that I would like to discuss. With limited resources, we need to integrate resources as much as we can. We have seen how COVID, HIV, STDs, TB epidemics have commonalities, and solutions should be considered as integrated and upstream approach to address the root cause of disparities. Improving access to HIV services for Hispanic Latino MSM will require acknowledgement of their cultural heterogeneity and diverse experience, which may shape risk and health behaviors and have important implications for the developing of implementation of HIV health interventions. It's going to be important to conduct rigorous evaluation of HIV prevention and care programs addressing social and structural factors, and scale up programs addressing social and structural barriers that demonstrate an impact in improving outcomes. Work for the development and cultural sensitivity is going to be essential, and it's going to be important to implement cultural sensitivity and linguistically appropriate interventions with HIV service providers and staff that acknowledge the diversity of the HIV-affected population and reduce provider bias. It's important to create a process to incentivize the recruitment and retention of HIV providers in rural areas and other underserved communities. And then at the policy level change, it's going to be important, given the current US political climate and ongoing debate about immigration and healthcare policies, to increase the urgency of understanding and addressing increased HIV burden among Hispanic Latino MSM, be aware of local impact of HIV criminalization laws, immigration, and other anti-LGBT legislation, implement institutional policies that address institutional racism, xenophobia, and homophobia, and anti-gay stigma, and implement policies to routinize the collection of data on social and structural factors affecting Latino MSM. Develop policies to ensure health coverage of everyone living or at risk of HIV infection. And last but not least, cultivate and support emerging Latinx leaders. Next slide. I would like to share these 2 documents that I think are relevant to this discussion. To the left, a call to action addressing the HIV crisis among Latinx gay and bisexual men who are bisexual men in the United States. That was developed last year and is currently available at the Impact Global Action for Gay Men's Health and Rights website. The call to action has been signed by many national leaders, Latinx leaders, and organizations, and it calls to address both the HIV service needs of Latinx gay and bisexual men in all parts of the country, and the need to fully fund and scale up tailored prevention efforts where new HIV infections are rising. It calls on allies, policymakers, funders, and public health officials at the local and state level to work together with the community on an urgent solution. The document to the right is an O'Neill Institute policy brief published also last year that includes a policy roadmap to promote health and reduce HIV transmission among Latinx and bisexual men. So to sign it, you can go to the website, and that is right there. Next slide. So in summary, inadequate focus on Hispanic Latino MSM relative to other HIV risk groups has allowed a compounding of HIV burden among these men. Efforts to prevent to better understand and address HIV-related disparities among Hispanic Latinx MSM are now urgently needed. Ending the HIV epidemic in the US will require ending the epidemic for people of all races, ethnicities, and risk groups. An effort to address disparities among Hispanic Latinx MSM must be in parallel to efforts to prevent new HIV infections and improve HIV care for Black MSM, not at the expense of these efforts. So it's going to be important to combat HIV-related disparities among Hispanic Latinx MSM. We must understand how, where, and why they arise, and we should act swiftly on available data about HIV incidence in Hispanic Latinx MSM to prevent another public health calamity. Next slide. Well, thank you.
Thank you, Dr. Mena and Dr. Ramos. And now I want to open it up for questions. We did get a few questions in the chat function, so I'll start with those, but feel free to add more questions as we move through. We have a few minutes for questions. And then I will also it'll also give a little time if someone has questions using the interpretation line to be able to share those questions as well. So the first question is it difficult for people living with HIV to get HIV medications in the South?
So that's a really good question. I mean, I think in theory, you know, in theory, the structure is there. So it wouldn't be, right? Because the Red and White program provides, you know, medications for free for individuals who are uninsured and no cost to the individual, regardless, you know, of whether they can prove that they are, you know, documented or not documented. But the reality is that because of the anti-immigrant, you know, initiatives and policies, you know, many Latinos, you know, who may be undocumented are afraid, you know, to access services. Think about the recent legislation or recent, you know, policy put by the government, where individuals who accept, you know, or who benefit from certain government aid, you know, may negatively impact their ability to become, you know, a resident or citizen of the United States. And just that, you know, we have seen in our states that have had an impact in individuals' retention in both HIV care programs, as well as in our efforts to help, you know, people to be persistent in pre-exposure prophylaxis program. So while it shouldn't be, there are many, you know, again, policy issues that really affect the access.
Great, thank you so much. This is a question for Dr. Ramos. Could the increase in rate be attributed to greater testing?
So I'm not sure which particular outcome, but I'm assuming that maybe we're thinking about the HIV health disparity. And so I think at the beginning of my presentation, I tried to do a job, a sort of a reasonable job at separating the estimated new infections, new diagnoses, and then the rapid transmission clusters. And so what I was trying to do was I was trying to highlight, Kelvin and everyone, that some of the argument is that new diagnoses means progress. That's what a lot of some of the leadership says about this issue. But I would argue that the estimated new infections that have increased among Latinx Hispanic populations suggest that those new diagnoses, a lot of them are also new infections. And if you think about the molecular cluster data, with a significant proportion of rapid transmission events happening under the age of 30, those are folks who would have been living with HIV for a shorter amount of time because of their age, and they're likely to have acquired HIV in the not so distant past. And so I actually would sort of maybe push back a little bit on the idea that we're doing a better job with testing. The testing data for Hispanic Latinos across the country suggests that roughly half of Hispanic Latinos have never been tested. And the truth is, I think that we see that there are sort of new infections that are happening at a rate that's higher than what we would expect.
Thank you. I think this is a question for Dr. Mena, since you brought up the lack of providers and researchers. So a question is, why aren't there more medical professionals that are Latino?
You know, I think that's a fantastic question. I think it should be, you know, the really focus of a intention and policy to change that. You know, you can't turn a switch on, right? And suddenly, you know, assign people, you know, now you're a Latino doctor, right? You have to create a pipeline. And that pipeline starts, if you think about it, you know, sometimes in early childhood education. I mean, so we really have to think about almost like a life course, you know, or a really upstream investment, right, in our Latino communities to improve the quality of early childhood education and education in general, right? So especially in the STEM, you know, in the science area. So we have then a cadre, you know, of Latinx, you know, individuals who then can access, you know, medical schools, you know, and scientific programs, so they can, you know, take care of the needs of their communities. In the same way, you know, you have to build, you know, a process where those emerging potential leaders, you know, can really be mentored and can be supported so they can serve the community. So that's kind of the challenge. And I think, you know, one that is not going to be addressed unless there is a very deliberate, you know, investment by all.
Thank you. This question is for Dr. Ramos regarding context. How can one measure sometimes intangible variables when trying to figure out or delineate context?
Sure. So I think, Judith, the two questions, Adrian's and also Danielle's, they both deal with context. And so I'm going to probably just try to answer both of them because they're sort of asking in similar kinds of questions. So I think, so Adrian, great question. I think you're tapping into something that's actually very, very important. You know, I would say that, you know, my wish is that we could somehow think as a Latino Hispanic community around studies that would allow us to look at sort of across the different contexts, how we have a set of shared risk factors that may in fact be true irrespective of where we are, and that we need to understand what those proximal risks are. But then we also need to design studies that allow us to really think about how the context and the context of how the risk occurs, whether it be sort of at the individual level or the institutions or the policies, how that context shape the things that we know are sort of true irrespective of where we are. And to me, that requires sort of mixed methods work that tries to capture not just individual risk, but also what's happening in the broader context. It is hard, but I think people's perceptions of their context, as well as sort of data that's objective about the context, and then obviously studies that are specifically designed to sort of capture both of those things, are kind of what we need for the future. I don't know, Danielle, if I answered your question, but I think it also speaks to some of the issues. Sorry, I don't know, Danielle, if I answered your question, but I think that it's sort of getting at the same sort of issue about how do we start to think about the Bronx is not just a specific context, but also are there other communities across our I'm sorry, I apologize. It seems like I don't know, is this a Zoom hack, Judith? Is this officially a Zoom hack? No?
No. Someone's trying to get some work done.
I'm just not sure if we're being hacked or not, which would be kind of cool, actually. It means that we're saying something important. So anyway, I don't know, Danielle, if I answered the question, but I think the same basic response, that we need studies that will start to not just be about a specific place, but that can capture, you know, commonalities across settings, but also what matters within specific settings.
Great, thank you. And we have a question that really is very timely because we know that firsthand testing in Latinx communities is stigmatized. Is there a way, have you all seen any home testing that can be done or a process to reach out to the community to encourage testing and treatment besides just parking a van in the street that says HIV testing because no one wants to go into the van?
So Dr. Mena?
Yeah, I'll be happy to, so absolutely. I mean, I think, there are many ways, I think there are ways that you can, de-stigmatize, HIV testing. I think, HIV, takes care of one issue, right? If you think about, health and approaching health in a different and more comprehensive way, HIV testing is something that should be done, when you get a once a year, a wellness exam as part of other tests that are typically done to check your blood sugar. You get screened for STDs if you're a young person, you meet that you check your blood pressure, you check your BMI. So that's one way to do that, right? The stigmatizing. There are, HIV tests that are approved, home-based HIV tests that can be purchased, in a pharmacy, in any pharmacy. That is called, it's an oral test that is good enough, that's pretty good. The cost is about $45. And right now, I think, for the past several years, there are a number of companies that are working with, and researchers really that are looking into ways to give people access, to home testing, using different technologies that can be very accurate. Some of it can give you, the results right away, like the home test that I mentioned. Some of them you have to email, a little card, and then you get within 1 week the results of the test in a very accurate way. And there are, people exploring ways how as you receive those results, you can be immediately linked, to a healthcare provider using telehealth, so you can get, so you can develop a prevention plan if the HIV test is negative, and you may benefit from, prevention, or you can start, your linkage to HIV care if the HIV test is negative. The answer is yes. I know that many cities in the country, health departments, I know that the New York has been doing that for quite some time. People can actually request a home HIV test over the phone. So, yes.
Great, thank you. It looks like that's all the time we have for questions. I want to thank everyone for their participation. We are going to save your questions to pass them along to Dr. Mena and Dr. Ramos, so we could get those answers for you all later. Please don't go too far. We do have 2 more sessions this afternoon. So please stick around, and please also fill out your evaluations. Thank you, everyone. Thank you, Dr. Mena.
Dr. Mena. Take care, guys. Be well.
Bye-bye.
Bye.